us, that's fine. Hi everyone, just want to echo what Sarah said. Thank you all for joining us tonight. We know that finding an hour right now is extra crazy, so we appreciate it. My name is Lindsay Manis. If there are people on the call that I don't know, I am a PA at Hopkins. When Sarah and I were talking tonight about what the best format would be to go through things, we really decided just to keep this pretty informal and cover a broad range of topics, hoping that at the end we'll have some time left and we can really just open it up for discussion to hear from each of you about how people are doing and if there are any issues or conversations relevant to your practice that you would rather hear instead of me rambling about things. So just going to somewhat quickly go through some ways that COVID has affected HPV surgery and cancer care, review some information about telemedicine during the state of emergency, go through a couple of areas where I think COVID has highlighted the APP skill set and the need for us, and just cover a couple of the lessons learned during my COVID deployment. And then I'm going to hand over to Jenny, who is on the call, to share a little bit of her experience being in New York City and also with her own COVID positive experience. And then Sarah's going to walk us through a case study that she has of an HPV patient who tested COVID positive on the floor postoperatively. And after that, we'll just open it up, as I mentioned, for some discussion. So this slide you guys have probably all seen. I took a snapshot of the Johns Hopkins University tracker from this morning, which clearly shows that COVID continues to be active and on the rise across the world, with the United States largely outpacing many of the other countries. I thought that the graphic at the top was somewhat interesting. It is the curve by state. And again, no surprise that the Northeast has flattened out a little bit, though some states are starting to rise, and our friends and colleagues in Florida, Texas, Arizona have seen higher levels over the past month. Again, I expect that this information is not unique to Hopkins and that many of you have had the same experience, so I don't want to be redundant. But we did, in late March, elective surgeries were canceled basically immediately. A lot of this, at least here, was driven by PPE. And we just had a leadership presentation yesterday, and our projections for the Hopkins surgery volume is expected to be about a 1-year backlog to try to get through cases, which poses a lot of future operational challenges and staffing challenges, and I'm sure that you guys are all facing the same. Around the same time, we really cut our in-person clinic visits down. Only post-op and acute things were seen in person in clinic. We implemented visitor restrictions, which have been very challenging to stick to and to roll out across the house. And we eliminated in-person patient education, both preoperatively and at the time of discharge. And this, as I'm sure my outpatient colleagues on the call can attest to, this significantly increased the outpatient call volume and work burden. We are basically sending patients with new drains and wounds and new diabetes home with teaching over FaceTime, which certainly is not ideal. Related to cancer specifically, we were fortunate that we did get to continue with our cancer cases. Those were not considered to be elective because we did have enough PPE to keep going in some situations. However, our more indolent diagnoses, such as neuroendocrine tumors, IPMNs with high-risk features, GIST, et cetera, were postponed. And so right now we find ourselves in a really sort of interesting scenario where we have these tier 2 diagnoses, as we call them, who have been postponed 2 to 4 months. And now their tier 2 diagnosis has been bumped up to a tier 1 effectively because of the timeline. And now we're trying to integrate and get those cases done along with the new cancer diagnoses. So certainly some challenges there. We did have some patients who elected to continue chemotherapy, and this helped sort of temporarily in the short term, but we know that this won't be a good long-term solution. We saw clinical trials shut down, which is something that really was disappointing to a lot of patients and families, and that's something I'd be interested to hear, what other institutions have been doing related to this. We saw and continue to see some procedure delays related to both diagnostic and therapeutic procedures. We have a large out-of-state patient population. About 61% of our patients come from out of state. So we're used to trying to coordinate care in patients' local areas, but the extra layers of challenge and care coordination that has been involved during COVID has really been significant. And then, of course, our favorite thing, the postoperative fever, which in the era of COVID has become a whole new animal about how to take care of this. And the case that comes to mind, I don't think I'll ever forget it. We had a patient who had a PVD in place. He lived in New Jersey. He was scheduled for routine exchange, but this was postponed because exchange is considered to be an elective procedure, not an urgent procedure. So no surprise, about a week and a half later, though he was still within his window, he called me and was febrile. So I scheduled him to come into interventional radiology. His wife drives him down from New Jersey. She drops him off at the front door because she, of course, can't come in with him. He gets to the screening checkpoint and is denied admission because he has a fever. So he calls his wife, who picks him up, and now they're sitting in the parking garage, febrile, calling the office, very upset because they can't get in for their procedure that they're scheduled for. And so this really was an incredibly difficult process while the hospital sort of figured out their workflows, and we were able to get some exceptions made and figure out some workarounds to be able to care for these patients, because not every febrile patient has COVID. But I think that this is just another true testament of the sort of unseen work and care coordination that largely falls on our advanced practice colleagues. And then, of course, through all of it, we've frustrated patients and families who are going through cancer treatment. All of these restrictions and workflow changes are in the benefit of the majority. But when you're a patient with cancer and you feel that you're dying anyway, all of these COVID restrictions and delays are difficult to accept. So trying to be sensitive to our patients going through that. At the same time, as all of this telemedicine was blowing up across the country, at no surprise, healthcare lags significantly behind the rest of the world when it comes to technology. And Hopkins was, right there, not ready to be able to roll this out on such a large scale. We went from seeing about 50 visits, they said, as a health system each week on telemedicine to about 20,000 visits a week. And so our platforms were not able to or equipped to handle this volume. So there were a lot of growing pains with that, just related to the operations. There has also been significant confusion around national and institutional guidelines, and I'm not going to get into the nuances of this because, of course, it varies by state and institution, but I do just want to cover a couple of key points in case some of you are not getting good information from your institution. But one of the major complicating factors was Medicare, who previously considered telemedicine to be a non-covered service, announced that they would expand their coverage for telehealth services. So everybody was running around here talking about how now we could see all of our patients and our problems were solved. But this wasn't actually the case. And so if you are doing telemedicine or you intend to continue doing telemedicine, there really are two key considerations to keep in mind. One is the visit legal, meaning is it within the scope of your license? And the second is the visit billable. Medicare, as you know, is a payer, and Medicare can deem something to be a covered or non-covered service, but Medicare does not have the ability to or authority over your license. So Medicare cannot say that it is okay for you to see a Medicare patient who lives in another state. And this was a big point of confusion for some folks here. Of course, telemedicine guidelines, as I'm sure you guys are all aware, is dependent on the individual state. It varies by state, and it also can vary within the state for new versus established patients, and then the credential of the provider seeing the patient. There are frequent revisions to this, so it really is important to be staying on top of this information if you're doing it so that you're sure you're compliant with your license. At Hopkins, our HPB faculty in advanced practice were able to obtain temporary and permanent licenses in 11 different states. We've done about 800 video visits since the end of March, and we converted our patient education classes over as well for Whipple, and we've seen about 130 people, half patients, half caregivers, through that. And I think what this slide illustrates is that we have demonstrated that we can provide safe and quality patient care through telemedicine. I think that is something that's widely accepted at this point. But what is unclear is how we're going to continue to deliver that care once the state of emergency ends and the regulations change. So as we look to our post-pandemic future, what will that look like from a regulatory standpoint, and how do APPs fit into that? Just again, a couple of considerations as the legislation starts to change. There are waivers that are expiring, executive orders are being terminated, the disaster credentialing will be pulled back. And so if you're somebody who has taken on some new skill or been deployed to something else, just really important to make sure that you're aware of all of these regulations, legislation, policies as they affect your practice. We're fortunate here that we do get pretty good communication about that, but we don't have any central office of advanced practice or anything. So a lot of the information that comes out is related to the physician. So if you don't have somebody who is looking out for APPs, just keep these things in mind. Related to telemedicine, there is an interstate licensure compact that exists for physicians. There is not one for PAs. There is one that's pretty rudimentary for nurse practitioners. And so all of these things are starting to be looked at, but those are more long-term strategies. I know that our legal counsel has said that there are talks about a telehealth license coming out, or national license reciprocity. So, again, just things to keep in mind and look out for. If telehealth does expand, the different considerations that we talked about before, location of the patient, type of service, type of provider, all of those things are going to factor in who can do and see what. And if you have the opportunity to advocate within your institution or within your state for APPs to be included in those initiatives, I think it's a really great opportunity for us to hopefully be included at sort of the first pass. And then I did include down here in red with a link that Florida actually is the first state to offer a permanent telehealth license, and it is open for APPs. So I applied, it took about 3 days, it was $25. It was a very easy process. I did talk with the Florida board. Obviously, I'm a PA, and I asked if my supervising physician had to obtain that license as well. They told me it was suggested but not mandatory, and they actually gave me the license before my supervising physician applied as well. So if telemedicine is going to be something that you're going to keep in your practice and you haven't heard about this Florida license, you should definitely check that out. This slide, highlights a super ridiculous picture of me in what was our makeshift COVID workroom at Hopkins. So I did deploy to one of our COVID IMCs, which was one of our units that was created to and sort of upskilled, as they call it, to be an IMC for COVID. Our facilities team sort of made plywood walls for us in the middle of waiting rooms, and you can see our luxurious accommodations here. I'm wearing my PAPR hood. It wasn't attached to the battery pack, but it was sort of just for effect. But this is something I just wanted to share because I know that there is a lot of anxiety around deployment and how is the best way to do that. I'm not sure if other people on the call have been deployed as well. If so, would love for you to share your experience when we get to the end. But I do think that the anxiety associated with going to COVID in the end, as I look back, was a little bit worse than the anxiety of when you are in COVID. And I think that's pretty consistent with just, the unknown. There are some pretty foundational tenets of practice that I think make APPs really equipped to stand up and to volunteer in these situations. We are very competent providers with versatile skill sets. I think, we're one of the most flexible and willing to help groups of people that as a whole that I've ever encountered within the hospital. And I think that's a testament to all of us. And at Hopkins, our surgery APPs were the first ones at the line to volunteer. And so we were deployed to all of these different medicine units. And it really was a big change because as we're surgery, obviously, and this is medicine, and these people have every problem, under the sun in terms of comorbidities and exacerbation of those comorbidities, as I'm sure you guys all know. And I've been a PA for 11, almost 12 years at this point, but I have been outpatient my entire career. So the first time I ever saw or used inpatient Epic was my first COVID shift, which was terrifying because I didn't know how to do anything. And that was actually one of the hardest things about all of it, was just not knowing what to do. So that was certainly a challenge, but I think my background in HPV and being used to these complex, high acuity patients was helpful. Certainly being comfortable with difficult family and end of life conversations that we all have all the time was really a useful skill set, especially because for the most part, people's family members were not in the hospital. You're having that conversation over the phone. And so there was a lot of skill that could translate there. The APPs, as I have said a couple of times at Hopkins, really has stood out as being an exemplary group of people. I was sharing with Jill before everybody started that this unit that was created, as I'm sure is the case for many of you, was a COVID IMC unit that was created on our old transplant surgery floor. So the nurses were used to taking care of transplant patients. The physicians who staffed the unit were rotation of anesthesia and pediatric ICU attendings, and we would have a new attending every 1 to 7 days. And so the APPs really were the steady state on the service, which is again frightening when it's me because I didn't even know how to use Epic. But I think it really was a very collaborative experience overall, and I found that people were willing to help and were kind and considerate of that. But it really was the advanced practice who ran these new makeshift units and gave us a really good name across the house. And because of that and through that, we've had some opportunity to interface with our executive leadership and legal counsel, again, about advocating for APPs to be included in some of the different lobbying efforts that Hopkins is doing, again, related to bills and expanding scope and different things like that. So I really think that through all of this, there will be some positive things that will come out for our profession, and at least some recognition, which is great. And now I want to invite Jenny, who many of you know, to share her experience with us. Jenny obviously is at Memorial, and so is right in the middle of things in New York City, and also tested COVID positive herself and was ill. So we're very glad that Jenny is back and is doing well, and would love to hear her experience with that.
Can you guys hear me?
Yep.
Okay, they just put the webcams in like 3 weeks ago. So I didn't know if you could hear me or not. Yeah, so this is my my one viral moment, I guess. My Facebook post got shared like 500 times because I was sitting at work and I was not feeling well. And I'm like, I'm not going to get this. And I kind of came home from work and told my husband, like, I'm totally getting this. There's no way I'm not. In New York, I just would say that we were like totally blindsided. The first hint that I had that anything was wrong was actually the night before I was leaving for the AHPBA meeting. I had everything packed. I had a 4:30 Uber picking me up, and all the surgeons got out on Wednesday. And I picked my mother-in-law up at the airport and came home. And Peter Kingham sent me a text and said, I don't think you're coming to the AHPBA because they just banned all travel. Up until that point, it was completely business as usual at the hospital. And then it was like we went into complete like panic mode. So canceled my trip. We had a big staff meeting the next day talking about limiting staff travel, what to do if you work with somebody who gets exposed, then you have to quarantine for 14 days. It was just kind of a mess. So the next week I got redeployed to employee health, and that's pretty much where I got exposed, because in the very first few days we weren't set up for employee testing. So I was basically 3 feet from a febrile 24-year-old nurse without a mask on, and I took her temperature and she's burning up in front of me, and then she tested positive, and then like 3 days later I tested positive. So personally, it wasn't that bad. I felt really tired. Well, then when I went home and I was working from home, the following day I went and got tested. So then like even 3 days later, we had it better figured out. So at that point we we actually used school buses at all of our regionals, and had a designated site in Manhattan for employee testing. So I pull up, drive up to the school bus and walk up the back, put myself in PPE. They do the brain biopsy, basically. And then I went home, and then 12 hours later, I found out I was positive. So this is kind of a good, we kind of had to think quick on our feet, like institutionally. We set up a COVID team to manage employees and patients who tested positive. So once we figured out the testing, we were able to turn it around really quick, because in the beginning of March, we were sending all the tests to the CDC. We didn't even have an ability to test for it. So I got my test back. Then this COVID team basically checked in with you every day. It was mostly staffed by APPs, and they made sure that you were not deteriorating. And they did the same thing for staff and for patients. So we were able to keep a lot of patients home. We even gave them pulse oximeters to take home. We were just trying to manage as many people as possible at home. The one thing that's different about Memorial, which I think MD Anderson is probably the same if I remember, is that we don't treat anything but cancer patients pretty much. So we don't have a typical emergency room. So you can't just walk off the street from New York City and be like, oh, I don't feel well, I want to go to the ER and come to the Memorial. So we didn't get the influx that Columbia got, or that NYU, New York Presbyterian. I mean, I have friends that work there that it was horrific. I mean, literally generator trucks of bodies outside the hospital. It was awful. So we didn't really get that at Memorial, but our employees, we had a pretty high, the highest rate of employee positivity was 40%. So we had to kind of like then pivot, because that's the whole reason why I got redeployed to employee health, was because we were putting everybody out on quarantine because they were exposed to somebody. And then like half of the hospital was out on quarantine. So then they changed that guideline, and then it was work till you're symptomatic, which was like, that doesn't really sound like a good idea, but that's what we're doing, okay. And now we're at the point where we have no positive COVID in patients, and our positivity rate for employees, I think, is 0.2%, and for patients is like 0.3%. Similar changes in the workflow that Lindsay talked about. I mean, I canceled 3 months worth of CIS patients, so I'm doing them all now. We opened up an extra clinic day for only televisits, and I'm seeing a ton of people virtually, still seeing some in person. We're back pretty much operating full time, so all of our operations are getting scheduled right now, and we're busy. We're really worried about the lack of care. I mean, New York City is still pretty much like completely shut down. So nobody is going for mammograms, colonoscopies. During the whole pandemic, the only patients we were seeing were jaundice patients, because people aren't going to ignore that, turn yellow in a pandemic. You're not going to ignore it, but a little abdominal pain, people are ignoring that at home. So I'm very worried about that. We were only seeing like hilar cholangiocarcinomas that were glowing in the dark, and pancreas cancer patients. It's definitely picked up now. Like now, I think people are back to going to the doctor and stuff like that, and we're in a good good bubble here in New York, but what's made it more complicated now is we've banned people from 36 states from coming here. So now we have to COVID test all of them before we can get them in the door. I don't know. I think we turned it around pretty quick. I think we definitely were not prepared. And I guess that's like where everybody was, but I guess kind of New York City kind of took it on the chin, and then the rest of the country is like figuring it out. But yeah, that's basically the way it is in New York. Anyone have any questions?
Thanks for sharing that, Jenny.
I'm
Glad you're feeling better.
Yeah, I'm glad you're
Thank
doing
you.
better.
My
It must
gosh.
have been really scary.
Jenny, what was employee health policy before you could come back to campus for work? Did they have a certain number of quarantine days, or was it from symptom onset?
Yeah, by the time I got sick, well, I tested positive on March 20th. So it was 7 days from when I first tested positive. And then I had to be without a fever for at least 7 days, but you had to be without a fever for 3 days. So I thought I was going to go back like on day 7, but then I had that like relapse that people had. So I was kind of, I just stayed home and isolated from my kids. My husband was like, I don't think you have COVID. I think you don't want to homeschool. Which that would have been brilliant. Just sit in my old nanny's room and watch Netflix all day. But so then it was another 3 days of being out because I had a late fever. But I never had the shortness of breath. Like I had a fever, aches, I was tired, and I had like shortness of breath if I walked up like a flight of stairs, but I wasn't like coughing. And then I completely lost my sense of smell, which it's still not back yet. And then like for a month afterwards, I had this like annoying dry cough, but I was never like really sick, I would say. Just slept a lot. I was glad I never smoked. Honestly, the people that did the worst were people who were very obese, at least in our experience. But cancer patients so far haven't done any worse. And the pediatric cancer patients they're not doing any worse with COVID than regular patients.
Yeah, that's sort of what I saw too. Everybody
Yeah.
was basically overweight with poorly controlled diabetes, a little bit of, chronic kidney disease, and got tipped over the edge.
Yep.
All right. Well, Sarah, do you want to move into your case presentation, and then we'll just open it up to everyone, and if people have more questions for Jenny, she can answer then too.
Well, thanks to you both, Lindsay. I know that must have been really challenging to transition to that role, and I'm sure, like always, you did it with grace. But thank you, because I know that that's hard work, and your patients are very lucky to have you. And Jenny, we're so glad you're doing better. I can't imagine being in New York during this. Knock on wood, we've done okay in North Carolina. I will say that in my 10 years of practice, this is the busiest I've been clinically. Initially, when all of this happened, they platooned our residents. And so what that meant was they put all of surgical oncology under one umbrella. So we had one senior resident, one intern, and then myself to cover the HPV patients. So in the residents, we're also assigned 1 week on and 1 week off. So I was slammed. And at that point, our census hadn't really decreased much because most of the cancer operations were still moving forward. So again, I think it's a testament to the APPs and the continuity to make sure that these complicated patients had appropriate care. But it was very busy. And having allergies in North Carolina with multiple positive exposures, I myself had the brain biopsy a few times, but knock on wood, they all came back negative. So I'm going to transition my screen to show you some slides. I just want to go through one case presentation that I found interesting, and then we'll open up the floor to discussion. Can you guys see that okay? So this patient, MR, he's a 56-year-old gentleman with metastatic colorectal cancer. He presented back in January 2019, almost 15 pounds of weight loss, left lower quadrant abdominal pain, had a CT scan, ultimately demonstrating synchronous metastatic disease. There was evidence of a sigmoid mass, multiple liver lesions, ultimately biopsy confirmed adenocarcinoma, and had some lung nodules, which ultimately were stable, but he probably has, low volume metastatic disease to his lung and has since his time of presentation. He started on neoadjuvant chemotherapy, some limiting neutropenic colitis, dose reductions, but ultimately had a surgery in November of 2019 to remove what turned out to be 2 primary colon tumors. He had one of his liver lesions resected, another ablated, and had his pump placed. You can see his pathology here again, 2 primaries, node positive disease, and again, metastatic disease. He went on to have his pump chemotherapy and systemic chemotherapy. He had some wound issues, delay in his irinotecan, but ultimately his liver lesions were downstaged. He did need some help as his future liver remnant was a little bit small, around 30%. With his extensive prior chemotherapy, we wanted his liver remnant to be about 40%, and he got to a little over 50%. So he had a good response. Also had a DVT, so at the time of his PVE, had an IVC filter placed. And then we saw him for his right hepatectomy on June 2nd. He had actually gained almost 30 pounds, and so his hepatic arterial infusion pump was near eroding through his skin. And so because of that, he had revision of his pump pocket as well. He had been doing well until post-op day 3, and he had a fever of 38.5. Otherwise, he was doing fine. It turns out that morning he found out his wife tested positive for COVID. And so looking back at the timeline of kind of what transpired before his operation, his wife attended a birthday party on May 29th. He had his routine preoperative screen on May 30th and was negative. We're testing all of our patients within 72 hours of surgery. Right around the time of his operation, the wife apparently began to feel ill, got tested, and then turned positive. We then tested him, and his test returned positive a couple hours later. So at that time, he was transferred to the general medicine service to one of our COVID units. We, of course, were intimately involved in his care and followed him very closely, but he did have a medicine attending and was on our COVID unit. He had a bit of a complicated course. He had some acute kidney injury, which is probably multifactorial. We think some ischemic ATN, some medication-induced injury with NSAIDs. Can't rule out COVID contribution. His creatinine started to bump up right around the time that he developed his post-operative fever. Because of his AKI, he did miss 1 dose of his remdesivir, but generally was pretty asymptomatic from his COVID infection from a respiratory standpoint. He had some ascites post-operatively that was managed with diuretics, and he was discharged home on post-operative day 10. He then presented to the emergency department about 9 days later with new onset of abdominal pain and nausea. He had a CT scan in the emergency department that demonstrated active hemorrhage from the pump catheter insertion site at the GDA. He also had this large peridural hematoma, radiographic findings of pancreatitis, and had an elevated lipase of more than 4,000. So he then went to IR. And so again, pancreatitis led to this GDA pseudoaneurysm at the site of his catheter insertion site. The pump catheter was dislodged, and this required a stent placement from the interventional radiology team. He did have some celiac stenosis, but they were able to ultimately access the left hepatic artery and place this covered stent. You can see, here we go, here, his pseudoaneurysm. So a couple of days later, he had a bump in his LFTs, total Billy 4.8, conjugated 3.2. So this prompted some more cross-sectional imaging, got a repeat CT scan, and he had new celiac artery dissection. We had a really long discussion with IR about what to do next, and ultimately it was felt that any intervention was going to be higher risk than just relying on his collateral blood flow to his remnant. Talked about different medical interventions, and ultimately he was treated with aspirin, and Plavix was held due to concern for bleeding. His pump removal, ultimately, on June 29th, his pump was removed because he had that stent placed across a catheter insertion site. that eliminated his pump as a therapeutic treatment option for him. He again was having some skin erosion from even the pump reciting and had some local SSI. So for all of these reasons, he had his pump removed. That pump removal site was managed with a wound vac, and on July 2nd, he had significant bleeding with his first wound vac change. He had a drift in his hemoglobin, was transfused, had an inappropriate response, prompting another CT scan. On the scan, we saw basically progression of the celiac artery dissection. Interestingly, active hemorrhage into the pump pocket from a branch of the inferior epigastric, and again, findings of pancreatitis. This image here, I think, was a good demonstration of the pancreatic inflammation consistent with his pancreatitis. And then here we can see that kind of hemorrhage from a branch of the inferior epigastric right here. He went to IR, and at the time of his procedure, he did not have active extravasation, but they did empirically do a glue embolization, which he responded well to. After this, he ultimately stabilized, but because of his pancreatitis, he had prolonged NG tube. He required TPN. Ultimately, was discharged home taking PO, but we basically sent him home on 2 vital shakes a day, which is 500 calories each. So 1,000 calories with protein shakes and then whatever else he could tolerate. Ultimately, home health did not cover wound vac changes, which was disappointing. So he is still home doing wet to dry dressing changes. What I think is really interesting about his case is there was no other etiology of his pancreatitis. His gallbladder had been surgically removed. There was no alcohol. And in the literature search, we found that up to 17% of patients have some level of biochemical pancreatitis. This patient was persistently COVID positive, so he initially tested positive on June 5th. He was initially tested serially each week so that we could determine if he would be able to transfer back to the surgeon floor. At that point in time, they were requiring 2 negative tests 24 hours apart. At one point, he had 1 negative test, but then was persistently positive the following day. And shortly prior to his discharge, the CDC updated their guidelines. And so I just copied this from the CDC website here, where they transitioned from the test-based strategy to the symptom-based strategy. And so ultimately what that means is for patients with mild to moderate illness, 10 days after the first symptom, they can be removed from contact isolation. Not from resolution of symptoms, but from the first day of symptoms, as long as they are afebrile for 24 hours and their symptoms are improving. What that meant for this patient was that, when he came back to clinic, he no longer had to be on contact isolation. Unfortunately for him, he has some underlying depression and was very isolated during this postoperative course. And he is now recovering home with his family. Will ultimately need some more systemic chemotherapy, but he's got some more time to recover with his wound healing and whatnot, but he's doing okay. That's all I had for that presentation.
Thanks, Sarah. It was quite a case. Does anybody have any questions for Sarah, for Jenny? Any just general discussion topics that anyone would like to share? I know we have a couple folks from MD Anderson on the call, so we're excited to see you guys. We've been thinking about you out there in Texas.
Hey, we missed you guys. I miss seeing you guys at HPBA. I too, Jenny, was on the plane, supposed to be on the plane. My bags were packed, and we got the message Wednesday evening, and my flight was at 7 a.m. on Thursday, and that was it. That was all she wrote. Sarah, we had a similar experience actually with one of the liver patients that had tested negative, had their surgery, and one of the caregivers, so much older patient, the husband is older, but they brought the son with them to be the caregiver. So they were staying at the hotel, and they called to tell us that, their sibling who had been with the patient after their COVID testing, but before the OR, was positive. And so it kind of turned into a quick panic mode of, oh no, did they convert in the time that they had the COVID tests, hung out with their family, had the surgery? So we had to do the testing on the inside. Luckily, they were negative, but then we had to get the rest of the family tested. And what we found that was challenging was finding a site that they could go to when they are from out of state, and that, you know, the institution was covering for the patient but not for their family members. So we were having to get online to, you know, Google the .gov testing sites and things like that, and that took up an obscene amount of time of just trying to find a location and where do we send these people, how do we get them there, they don't have vehicles. So it turns into a lot more resource allocation than I think we had anticipated. But now that one of us has gone through it, we now have like a list of, okay, here are the locations that you have to send a family member to, and they have to pay out of pocket for X, Y, and Z places. But it's just kind of learning as you go, like I think everybody's experienced.
I think the community spread is interesting. We've had a few positive patients and they have all unfortunately, caught COVID from a family member. So we had, this patient that I just presented, we had a very heartbreaking case of a 48-year-old woman with cholangiocarcinoma who had, systemic chemotherapy, had a pump placement, had an extended right hepatectomy. Unfortunately was having, had post-hepatectomy liver failure with her billy peaked around 22, 23, but about 2 months in, she was starting to turn the corner. Her liver function was recovering. And then Duke had, at that point, opened up visitation for one visitor the entire stay. Her husband hadn't seen her in almost 2 months. He saw her. He turned COVID positive that weekend. She got COVID and died from respiratory hours. So it was probably one of the most emotionally challenging cases that I've had, because I had been communicating with the family via phone because they couldn't be there in the hospital. And then, like any spouse would do, he came in to see her and had to deal with the guilt of, being the loved one that transmitted COVID to her and she passed. She may not have had the best outcome, big picture, but it was just a much quicker demise than she should have had.
It's really sad.
How
Morgan.
often are you testing now inpatient, Sarah?
So we are testing within 72 hours of an elective surgery. And then they just sent out an email last week. They are now testing all admitted patients. So initially only pre-procedure like endoscopy or OR cases were being tested, but now all admitted patients are being tested.
Same with us.
Be helpful.
We've been testing every 3 days since the beginning.
Oh, all patients. Is it
all
patients?
inpatients? All inpatients. Every so you get tested pre-op, and then you get, if you come in through urgent care or SCC or something, you get tested on arrival, and then while you're in the hospital, you get tested every 3 days.
Wow.
Interesting.
For all inpatients, and we've been doing that since the beginning, and obviously the pre-procedure and all that sort of thing. We've just opened up visitors to one visitor for like 4 hours a day per patient. And
we're still on strict criteria too.
Have somebody come with them to a procedure, but then they have to leave the building and can come back when they're done. But in the beginning it was awful because it was like literally leave them at the front door and we'll call you when you're ready to get picked up.
I think another thing that fell on the APPs too is, you have a whole service of patients and they are going through, a major operation, cancer diagnosis, et cetera, and they can't have a family member there. So, if you're calling family members of 15 patients, that adds a significant amount of time to your workload.
Yes.
And they typically fall on us, which we're happy to do, but it's something that was, we had to take into account for because it was very time consuming, but I think the families appreciated it very much.
Yeah,
Are any of the staff members getting routine testing, like the inpatient APPs or anybody inpatient?
We have the ability at Anderson to get every 10-day asymptomatic testing as an employee. So many of us have chosen just to go. So I'm getting my third. I'm waiting for them to call me because I'm about to get my third one scheduled here shortly, just so I can feel better about being around my parents and my child and that kind of thing. But yeah, if you're symptomatic, they have our app, our COVID app on our phones, and you're able to just click through it, and it's covered under the insurance, because I've looked at the bill. There is no, out-of-pocket payment or anything. And then you're allowed to go to any of the, there's like 5 or 6 locations that you can go to for employee testing. It's pretty quick in terms of scheduling, and it's pretty quick in the turnaround's about 24, 36-ish hours in terms of getting it back. I know there's some, if you go travel or something, then you have to if you take a step out of the state of Texas, then you've got to get tested a couple times before they let you back in the building, kind of a thing. But yeah, you're allowed 10-day asymptomatic testing.
We're not testing, but because I was deployed, they're testing our antibodies every 60 days. So I
wish we were doing antibodies.
I was really hoping I had some, but I don't. But it was, I think, 7 out of 250 people on the first draw had antibodies. So, again, as sort of Jenny shared, lower numbers here than what they saw in New York for sure.
Yeah, we had, you can do an asymptomatic test every 7 days here for employees, and then you can get antibody tested. We rolled it out originally to just the people that were taking care of COVID, and then it was all clinicians, and then now it's basically anybody in the hospital can get antibody tested. And in the first round of antibody testing, only 5% of asymptomatic employees had the antibody. So I don't think a lot of people who are like, oh, I had it in February, no, you didn't. But I do have the antibody, so. But none of my kids have it, or my husband. So
we're only testing symptomatic. So even, known exposures, you basically call employee health, and they categorize it as low, moderate, or high risk. They have a very low threshold to test, but they have no asymptomatic testing right now.
Yeah, for us, they encourage testing if you've been exposed, even if you have full PPE. So you're considered low risk, but they still encourage testing, the minute you're notified, and then again at day 7 to be tested. And then they offer us a stipend for a hotel stay at certain designated hotels around here. So they'll pay, I think, up to 2 weeks for you to stay in a hotel if you feel like you've been exposed. That they'll let you stay there while you're kind of waiting for test results, or you're feeling symptomatic and you took care of somebody, you're concerned about that, and that's really nice. And they give us 10 extra days of sick leave for COVID if you're home because of COVID related exposure. So they give us that. But they're pretty lenient with testing. If you feel like you don't feel good, you just do testing. Yeah. And lots of telehealth. I mean, I try to do all my visits through telehealth if possible. If I have to do an in-person visit, I actually try to call the patient over the phone ahead of time to see how they're doing. And then when I get there, I've already done my history over the phone. And then I'm just looking at the incision or removing the staples, but I'm just in and out, as quickly as I can. So.
Have you guys found that, how do you guys feel about your institutional response in terms of utilization of APPs or acknowledgement of the additional work created because of COVID, sort of through the experience like I shared and what Morgan shared about, just all of the extra layers of care coordination have been added? Do you feel that that's something that is known to your administration, institution, as they talk about furloughs and all these different things are kicked around? How do you guys feel about that?
Well, I can say from our perspective, I think they've done a really good job of acknowledging the burnout factor of just in the beginning, I don't think anybody thought we'd be still dealing with this 6 months later, which clearly we are probably for another year or so. But they did a good job at reimbursing for travel costs, Uber rides, providing accommodations. They made a commitment to not terminate to not terminate anyone. They're not adding any new positions right now, but nobody was going to lose their job because of COVID. They did much better with the PPE once we got past the initial, people telling you to use your N95 over and over again. It's like, wait, what? Like, you're violating everything I ever learned in nursing school. But we just kind of did what you had. You just kind of did what you had to do. So I think they're doing a good job of it now. They're encouraging people to like take vacations because this is not going anywhere. I think where we were lacking, but it wasn't just here, is that we were just like not prepared. Like as a city, as in New York with all these hospitals, we were totally not prepared. And then the frustrating thing was just the way things changed. Like I got an email, like the third clinical update was that once you get past 3 liters nasal cannula, the patient should be intubated. And I was like reading this at home, like, oh my God, why would we not put them on? That was what that's what the CDC was saying. And now that's totally changed. So I think we were unprepared, but I think our institution's doing a pretty good job of at least trying to make it right for the increased workload.
I really appreciate our institution's response at UT Southwestern. We're still saying in phase 2. They said that we're in phase 2 until Labor Day, and that's basically work from home if you can. And now we got a message last week that says we're going to be in phase 2 at least to January the 1st.
Wow.
Yeah, at least, if not rolling back. But we're still fully functional. We're elective surgeries are still going on. But if you can work from home, they want you to work from home so that you're not exposing, getting things from one another, and that you're social distancing at work. So like our admins, I haven't seen them since March. They're all working from home. You wouldn't even know the difference because they're so good at what they're doing, and everything is virtual. So like for us, if I don't have an in-person visit, then I can do exactly this all from home. But they just leave it up to us, but until January at least. So that's been really good.
I think our
We learned very.
institution
Oh no, go ahead, sir.
I think our institution as a whole did a good job acknowledging that as an inpatient provider, I don't have much flexibility with doing anything remotely. Because I'm an N of 1 on our service, I'm grateful for the division support because they had really great structure for the residents. But again, the APPs, we didn't get platooned. We were there full time. Many of us with young kids at home. So we're still working full time, have kids out of school, out of daycare. And then Duke, also did not terminate, but they did decrease our benefits. So, I realized that my workload increased and I lost some of my benefits, but 2 years ago, I would have been outpatient and I would have been very grateful for that scenario. So I think Duke as a whole for Global Duke did well. And then my division has been flexible. I'm actually switching to work Sunday to Wednesday so that I can start to homeschool my first grader. Send help. I'm a good PA, not a good teacher, but I am fortunate to have the flexibility to be home with my 3 and 6-year-old 2 days a week. And they basically said, we're happy to have the extra help on the weekend. Do what you need to do for your family, questions asked. But I'm hoping the numbers go down and they can go back.
That's awesome. We did the same, you're N equal 1 and we got, we're lucky with our inpatient APP or the HPB group, there's 3 of us. And I was on the volunteer list for COVID, did my orientation, kind of sat there and waited for the call to go out. And luckily, Jenny, like you said, we're kind of on our little island where we're kind of protected, I think, from the real chaos of COVID. But what we learned by having 3 of us is that we figured out how to work remotely. We had one of us was out for maternity leave when this all happened. And so we were down to 2, but we figured out that one person could be in house and could be the hands and the eyes, and the other person could be on the computer calling emails, consults, calling patient family members, doing all this stuff. So we learned to make this into a very big team effort. And so now that she's back, we're able to get 1 week in house where you're seeing everybody's patients, but the other 2 people are at home and taking care of all the orders, all the pages, all the, you know, kind of the scut work. And then I go to the floor and I'll tell them, hey, I think we need to change X, Y, and Z, or I'm sending them pictures of their drains, or I'm FaceTiming them while I'm in the room. I'm rounding with their attendings. And then that provides me 2 weeks of working remotely with, you know, the 8-year-old gremlin that I've got to pretend that I'm a teacher with here shortly. And, you know, I'm lucky enough to have, you know, grandparent backup. But it's forced you into learning new things and trying new things. I thought I was only a pancreas APP, but apparently I'm a liver and pancreas APP now. So this has expanded my my horizons a bit.
Yeah, I'll just comment real quick. Thank you guys for putting this together, and for you know, Lindsay and Sarah and Jenny sharing your experiences and so forth. I mean, you know, I would say that, yeah, New York took it in the chin for us, because I would say our institution was quite prepared with our response. It was pretty immediate. You know, right away we were, a lot of patients were rescheduled, cases were rescheduled, and working from home right away. And that hasn't, and just like LAN, our group is back to being fully sort of functioning, but also emphasizing working from home. I would say for the last 3 months or so, it's been pretty busy working on recovery strategies. You know, looking at, you know, the integration of telemedicine, survivorship clinics, increasing access to care, just trying to do things the new normal, the new way of doing things in the clinic. And so we're looking at a lot of innovative solutions and trying to do that. And there's like meetings after meetings. It's unreal at times, and it's crazy. But yeah, I mean, I would say our institution is quite prepared. I mean, not so much for our city and our state though, as you know, if you're around here, it wouldn't seem like there is a virus, there's a pandemic going around if you're just driving around or whatever. It's a little scary at times, and so I think we sort of have to deal with some of that a lot. But overall, I think things our institution, our leaders have got us pretty well prepared. We never got to the full levels of using some of well, barely, I guess, some of the COVID related you know, units or floors were, you know, occupied, but not to the extent where we had to redeploy or reassign beyond voluntary basis. So.
I think we've hit the 6 o'clock hour. Are there any last minute questions from anyone on the call? Well, thank you all again. Thank you to Lindsay and Jenny. Thanks for everyone for joining us. I look forward to having more of these. I think the virtual platform is here to stay, which is a nice way for us to network. So stay tuned. And if anyone's interested in presenting anything in the upcoming months, and, you know, please let me and Jill know.
Thanks, guys.
Thank you for organizing.